the quality of care bill and also the reproductive health bill that which we are working on. There are a lot of gray areas in this space. So implementation began around June last year, but we'll be continuing. Now that we have finished the inception phase, we expect to cover more grounds, and we want to be on board in terms of ensuring that efficacy and efficiency in this project's management happens. The strategic objectives are 6. One is to improve the availability of RMNCAH services through system strengthening, infrastructure, HRH capacity building, improving commodity security, and health information systems. Those are basically the building blocks of health systems. Scale up adolescent youth-friendly services, including empowerment for reduction of adolescent pregnancy. As mentioned by the PS, this is a top priority for us. 300,000 to 400,000 adolescent pregnancies is not acceptable. Family planning is one of this. Family planning is a vaccine for reduction of maternal mortality. If we are using vaccination as a reduction for preventable deaths from preventable diseases, then if you want to reduce maternal mortality, we should plan to get the children that we have planned as a family to get. If a girl is 15, 16, 17, 18, we have issues of legislation and issues of parental guidance and parental consent, but whoever requires, it should be available above 18. For between 16 and 18, we are working on something that we can agree upon that is sensitive to our culture, sensitive to our religion, sensitive to our policies and our laws. So adolescent pregnancy is an area where the partner is very interested, and it will really help us reduce, because 50% of the mortalities are happening in adolescent girls who are pregnant. Improve the quality of the service delivery through integration of quality improvement in service provision. We believe that we have achieved the coverage. If we have an 89% of skilled birth attendant in the last survey that we did, that is quite good. And it's a proxy, it's supposed to be a proxy indicator for reduction of maternal mortality. But the skilled birth attendant is not commensurate to the mortalities that we have. And therefore, we believe there is something in the quality of care that we provide. Mothers have come. They used to die at home. Now they are dying in the facility. They have done their due diligence. They have come. What is happening in our facilities? 75% of these deaths are happening during off-peak hours, from 5 to 7 in the morning and during public holidays. Are we available for our clients? It's not rocket science to reduce maternal mortality. There are countries that have less than 1 or 5 in a year, a whole country, per 100,000 population. 1 to 5. Singapore is one of those countries. And if our neighbors have done, we can do it better. Increased demand and integrated delivery by strengthening community health programs and linkage to primary health care services. Part of this is to strengthen our PHC. Through this initiative, we are establishing 50 new PCNs with their hubs and spokes. So this is really helping us. We strengthen the primary health care and the referral systems, then we will catch. And we improve on our delivery services, intrapartum and postpartum, within those facilities that are able to deliver. I know we are struggling with some policy issues with SHA in terms of dispensary. We have given the advisory to the PS and to the CS to give out the guidance on that, so that those bed capacity levels don't really interfere and increase our maternal mortality. Removal of financial barriers to access for maternal and newborn care, a transition fund. Within this is a presidential directive that we should provide for the indigent. And because the indigents are too many, we are not able to cover all of them, but we have prioritized adolescent pregnancies. Any adolescent that is pregnant and is registered, we will pay for their premium. so that by the time they come to your facility, they are covered, and SHA will reimburse you. So our plea to the counties is that please don't send away a pregnant adolescent because they are fully covered. We take their coverage as a priority, and so long as the documents are in order, we are not asking for very serious documents. We just want to know that they have gone through a system, that you, as the county, have given us their data, and we will pay SHA for their premium. If we pay for the services, this money will not be enough. Yeah, but we'll pay for their annual premium. Please don't send them away, and you can put that on our head. Enabling policy environment to support, this is important. As a nation, we are not short of policies and guidelines, but what is lacking is the implementation and the monitoring of this. The county selection criteria was done alongside with the consultation with the CoG, but we looked at our data that we have. We looked at several sources of data, the census of 2019, the facility mortality rates 2020, our KHIS data, and also the post-abortion care data that we have. We looked at high maternal mortality and high newborn mortality rates. We also looked at high teenage pregnancy rates and low family planning uptake. These are all indicators that can help us to see where our mortality is happening. Beneficiaries are, of course, women of reproductive age, newborns, children, and adolescents. And those are the top 20 counties. The top 20 counties are there that have all this brought together. The components in terms of looking at the strategic objectives are health infrastructure, medical equipment, and commodity security. For health infrastructure, because the input is really a lot, and infrastructure alone does not make huge changes. The first 1-2 years, we said let's concentrate on what gives us high impact interventions that can give us better results, and the partner is also has guided. And we know the counties have done quite a lot after devolution in terms of infrastructure. But medical equipment for maternal health, PAC, newborn, and delivery rooms. We have prioritized them, and we'll do them in phases over the next 3 years. Healthcare worker capacity, there are several trainings that we want to scale up. We will start with the TOTs in every county, so that every county has the capacity to train its own staff within their own counties and sub-counties. And also disseminate the policies and look at other policies that require. For example, the RH policy was very controversial. This week we are doing the RH bill, looking at provision of reproductive health services, maternal health, artificial reproductive technology, surrogacy, and all these things. And whenever you're doing the law, we have to refer to the policy. So we may be in a position to review that. And there are other policies like adolescent youth, young people's policy that has issues. We remove all the controversies and we go with a document that we can all agree on, move on and reduce the mortalities. Component 3 is health information system, policy enabling environment, and the transition fund. That's what we have explained earlier. Adolescent and caregiver scale up. How are we dealing with our adolescents? Are we castigating them, or are we giving them the right support? Unatoa mtoto shule, unatupa yeye kwa street. Is that the way you want to deal with somebody who has a potential to build this nation? And therefore, we are going to focus a lot, and we will visit every county, especially the high burden counties where we have adolescent pregnancy and adolescent sexual reproductive health issues, to co-create the interventions. There are issues of quality of care and youth-friendly services that we were talking about. Primary health care networks and community health, training of the community health workers on RMCH services for their referrals. We know we have issues in terms of direct delivery of services. There are things we can allow them to do, and there are things that we guide them to refer to the health worker. Project management and operations, that is the coordination mechanism for the project, and monitoring and evaluation. Those are the 7 components. I think I have looked at them, but improving infrastructure quality, we're looking at the BMONC equipment bundle. We have developed bundles per facility which we are going to support. We look at a few facilities first year, another few for the second year, so that as county is moving on, we are filling in a gap. Basic emergency obstetric and newborn care, comprehensive newborn care bundle, post-abortion care bundle, and also, of course, where we now procurement, warehousing, distribution by KEMSA. Enhance the capacity of blood transfusion. We know 45% of our deaths or 50% of our deaths are either postpartum or antepartum. And as a ministry, together with the PS and the CS, they have identified to strengthen our blood services. We have a few regional centers. We want to include more sentinel sites so that we reduce the time required to seek blood. Why will Mandera send blood to Nairobi for screening? This is not rocket science. We have labs, we have people, we train the people, fund them. So through the national government and through other partners, through the BRE project of the World Bank, we have prioritized ensuring that a mother should not die because of lack of blood or any other blood product. Component 2 and 3, I have mentioned them earlier. Quality of care is priority. Quality of care is top priority, and that's why we had to legislate. We also have policies that we have done. Our last survey on service delivery was about quality of care, and especially RMNCAH. So we have all the tools. We are getting support from our partners from different sources. We want also the counties and the national government to prioritize this agenda, allocate resources, allocate human resource for health. Having a newborn unit of 50 children and you have 1 or 2 nurses is not quality of care, isn't it? So ours is to bring you on board so that we have a common agenda of saving our mothers together. We do what we can do from our side. You also do your bit because you can do a lot at the county level. There are a few counties that have really done progress, and we need to benchmark with those counties. I think Makueni, Homa Bay, Kiambu, and recently Garissa level 5 hospital has done very well. We visited in April when they had 18 maternal deaths in 2 months. One facility. One facility. And today, the CEC is proudly here. I visited with a team from this inter-county MPDSR, from KMPDC. We went with an all multidisciplinary team. We only sat for a few hours. Few hours. I think we went there at 9 o'clock, and by 5 we had a report. We had gone through all the files, and that was just because of negligence. They did not require anything. Just an administrative change has made us come to this level now. For the last 4 months or 5 months, they have only lost 2 mothers. So if it can happen in Garissa, where we believe there was marginalization, there's health worker issues, it can happen anywhere. That's over 4 months. In just 1 day of visit has made those administrative changes. I want you guys, the CECs, to get involved and to take it as upon you. The CEC Garissa has a WhatsApp platform for only maternal referrals. If they get to know, if the health workers get to know that there is supervision, there is monitoring, and there is leadership and support, it will work wonders. We may not require resources, honestly speaking. We just require to commit ourselves at leadership. In Tanzania, I'm told the one in charge of maternal health has a national platform and he responds to every case everywhere. We are able to do that. Sindio? The CS is responding to all the CHA questions himself, isn't it? We can have him respond to all maternal referrals and have that kind of a caucus of the CECs and the directors to ensure that we can exchange knowledge and monitor maternal mortality or near misses. Adolescent health and caregiver, I've talked about this. Primary healthcare networks, I don't want to belabor much, and this is the project management and monitoring and evaluation. Priorities from our end is complementary support to counties where possible in equipping of the facilities. All those equipment and all those trainings will go to your counties. Now Tanzania had used this what is called Safe Birth Bundle of Care. They call it SBBC. They did a pilot in 2021, and they found that the progress is huge. They scaled it up, and that has brought their maternal mortality down by 75%. We have these bundles, but we have in different names and different whatever. I'll ask my colleague, Dr. Juliet, to maybe give you more insight, 1 or 2 slides extra, so that you can understand and pick it up. We have a plan to harmonize whatever we are doing that has high impact together with this, because this is a delivery model. It's not that something new, but it's a delivery model. Tanzania is not richer than us. Uganda is not richer than us. They are not much more educated than us. The capacity we have a better capacity. We just need to be better organized. Sindio? Advocacy and resource mobilization for county implementation. We'll make sure that we will rally this agenda anywhere we go, with the CS and with the PS. We have been in, what do you call, WHA. This was our top agenda. Wherever we go, RMNCAH, maternal mortality and newborn, is an agenda, and we'll pool resources. The BRE project that you know, this one, Beginnings funds another project that's coming on board, just focusing. They have different strengths. Beginning is something that is going to be focusing on level 4 facilities. Level 4 facilities. Maybe in every county we'll have 4 or 5 sub-county hospitals. Then we can move these other projects to the primary healthcare networks. That doesn't mean that you reduce your investments as counties. Please don't do that. This is just a transition period. You can see there are 2 years, 3 years, 4 years, so that by the time they move out, our systems are strong and our investments are solid, so that you don't backtrack. Blood transfusion, I have mentioned it. We're also looking for resources for that. Dissemination of the guidelines so that the counties are able to make their decisions without really referring to the national level. Training of counties on PDSR and newborn child and adolescent death audits. This is something we are particularly interested. We want to make sure that every county has the capacity to do their own MPDSR. What is the weak point is their response. We are doing almost 80–90% of maternal death audits. But the response is what we need you to get involved. If a mother died and the health workers have done their bit, the conclusion is that there was no oxytocin or carbetocin or blood, or the referral was late. What is the response? And the response needs to be ensured so that no other mother after this one dies of the same reason. So the R is what is weak. So the safe bundle, as I've mentioned, there was a reduction of Tanzania's model. Maternal mortality was reduced by 75%, and newborns were reduced by 40% by just changing the model of approach. The model of approach is evidence-based package of clinical tools, training simulators. We will have them in all your facilities. We are now debating whether you should place them in your MTC facilities or your sub-county at the beginning. But eventually we will have every facility that is providing delivery services to have a training center where A health worker is free for 2-3 hours. They'll come and do the simulation themselves and move on. It's happening at the facility level in Tanzania, and we can still do it. So, reduction of perinatal mortalities of 18%. It's called team-based, real-time data, team-based simulation and low-dose, high-frequency. Unarudia, like in every time you do the training, you are learning something a small bit. Here you have 5-6 days, shoot. We have been doing for the last 15 years, and it's not happening. We want to move it closer, so that instead of somebody being on the social media for an hour, they can come and spend their time here and make a difference in somebody's life. If you want more of this, I'll ask my team member, Dr. Juliet, to maybe explain more. This is the same thing in terms of graphic. These are the tools that they use, training innovation, in-service simulation. And we want also our new graduates from MTCs and the medical schools to be trained before they come, so that they are ready for the market and you don't have to retrain them. That's in-service training in all the projects that we are going to coordinate. Those are the tools, the clinical tools. The one that monitors the heart rate of the baby, the heart rate of the mother, the straight mask, how we are doing mask, what do you call the oxygen mask that we're using. There's a technique, it's called straight, 90 degrees. Small things. These are very cheap things if you look at the cost, and we want them to be in every facility before the end of these projects. Sustainability, must be always part of our whatever. So the request to you, the leadership of the county health management teams, is prioritize equipping facilities, human resource for health to provide RMNCAH services, especially at level 2, 3, and 4 facilities. Ukipata health worker, tafadhali peleka maternity, peleka kwa newborn unit, peleka kwa theater, maternity theater, and you will see how you can achieve results. Retain those who are trained in MNC. We trained a lot of people, but many of them, because ini kazi ngumu, is just a passion that keeps somebody somewhere. Ini kazi ngumu, so people will request, nimechoka, nimezeeka, I'm about to go, please remove me from maternity. That's why I brought back the training of the midwife. Midwife will only work in maternity, and we will train more midwives. We provided World Bank scholarship for them, I think about 10 years ago, and the numbers have changed. Otherwise, the country has stopped training midwives before we change the policy. Prioritize life-saving commodities availability. If you pick the commodities and ensure that, and they are very cheap, capitocin, syntocinon, they are very cheap, less than 20 bob, or 30 bob for that matter. If you provide this, we will take the equipment and the big things from you. Yeah? And this is possible. Family planning, 100 shillings a month. Chagolako, Mama Chagolango, I don't know what the name was before. Yeah? $9 for 5 years, an implant. That's less than 1,000 shillings for 5 years. Very cost-effective interventions. Pick up those things, the commodities, ensure that they are there, and we will fill in the gap of the equipment and the trainings that are very heavy on you. Prioritize the life-saving commodities and prioritize the response aspect of MPDSR. Thank you. Juliet, you want to shed some light on the bundle? The counties can begin with their initiatives, and we'll provide the technical support for that. Whichever county wants to start earlier, we'll start. Thank you.
I think we need to appreciate Daktari in, let me guide on how we are going to do it. That was a very nice presentation. Those of us who are passionate about mother and child health. So allow me to just ask that we do Nyayo claps, 3 of them for Daktari. Ulikunywa Nyayo? Thank you so much. If you are a Gen Z, then you will not understand, but you will follow what others will do. So let's go. Nyayo claps. 1. No, you've started very wrongly. Sijui mmeshiba sana. Kindly stand. Kindly stand. Wamama wasilale. Okay, the Nyayo claps, let's do them. Ndio damu pia isirculate vizuri wakati wa digestion. Let's do the very hard claps. Sawa sawa. 1, 2, 3, fungua. Thank you very much. Thank you, Daktari, for that presentation.
So good afternoon, everyone. My name is Dr. Juliet Omoha. I work at the Ministry of Health under the Directorate of Family Health with Dr. Bashir. I am in charge of newborn and child health, and I'd like to just share what is Safer Birth Bundle of Care. As Dr. Bashir has mentioned, these are interventions that have happened as a bundle in Tanzania. And just to show the progress, and as a country would like to implement this, and we'd like support at the counties for us to ensure that our maternal and newborn mortalities go lower. So I'll just share with you like 5 slides on Safer Birth Bundle of Care. And for some of you, I'm sure have heard about every woman, every newborn, everywhere, and what the national government is doing in collaboration with the counties when it comes to the same. So when you talk about the Safer Birth Bundle of Care, before the slides load, it's a bundle of care that was implemented in Tanzania when it comes to care of the mother and the newborn. Previously, there was a note that the newborn was being left behind. So currently, most countries adopted the care of the mother and the newborn. So under the bundle of care, there are different interventions that are in place. It being a bundle, we have the clinical innovations that I'll be able to share once the slides go up. We have different training modalities at the facility. This means that our healthcare workers do not need to go to, let's say, workshops in a hotel, be trained once on a training, then go back to facility. It is on-site, meaning all these clinical innovations, technical innovations, like I'll show the Mama Bathi, Mama Natalie, the Natalie dolls to resuscitate, to show them the correct use of resuscitation of the newborn and how it's done, is actually done at the facility. It's actually an intervention that is cost-saving, in that once we have all these equipments in our facilities, we will have specific trainers who are called facilitators. We will have mentors in the specific facilities, and they are able to train healthcare workers when they are at the site. So Uganda had actually implemented this, and with the implementation, I'll be able to share, it was actually implemented in 5 regions in Tanzania, and there were 300,000 deliveries in these 5 regions. With having trained our healthcare workers in this bundle and use of these interventions, between the year 2001 and 2024, the reduction was massive. There was 18% reduction in perinatal mortality. There was 40% reduction in newborn mortality, and 75% reduction in maternal deaths in these 5 regions. So it was shown that the gap was in terms of the quality of care being given to different patients at the facility level. So this is the bundle that we aim to adopt currently. We are not doing simulation-based, which had been mentioned by the PS and Dr. Bashir, and that is what we want to do in our different counties. Equip our hospitals, empower the healthcare workers to be able to train the other healthcare workers in the newborn and the maternity units, so that we are able to reduce our newborn mortality. When you talk about Iwene, Iwene is every woman, every newborn, everywhere. Iwene is a global initiative that countries have been discussing. The aim of this is to ensure we reduce our maternal and newborn mortality. That is in aim of SDG goal 3.1 and 3.2. The initiative is ensured that we work with the mother and the baby together so that we reduce both maternal and newborn mortality. Kenya adopted this, and the move started last year actively as a country, where we were able to meet all the counties' reproductive health coordinators and child health coordinators to sensitize them on this global move and what we need to do as a country to reduce our mortalities. So what we were able to do right now at national level, we've been able to develop the IWENE acceleration plan. And this acceleration plan shows the steps on how we are meant to reduce mortality at county level for the newborns, for the mothers, but then the counties are meant to adapt depending on what are the leading causes of death for the mothers and the newborns. So that's the move towards IWENE. And currently, as we disseminate to the counties and interact with different healthcare workers and leadership at county level, we actually want every county to have their own acceleration plan that is tied towards what are the main killers for the mothers and the newborns in the different counties. So we are also planning on an IWENE National Forum where we will have our top leadership. Our guest of honor is meant to be the president of this country, and we're expecting all the 47 governors with their health teams to be there to support this cause in reduction of maternal and newborn mortality. So I think in summary, that is it when you talk about SBBC and IWENE.
Thank you very much for that presentation. As I said from the beginning, we really have to be on a marathon this afternoon so that we can be able to catch up. So let's have the next presentation, which is the inter-county MPDCR, which is actually related to this. And then we'll have a very brief session of comments and questions from the rest of the members. Thank you very much.
Thank you very much, Chair. Good afternoon, everyone. My name is Mary Maina. I am a gynecologist in Kiambu County. I work at the Kiambu Level 5 Hospital. We have 3 presentations in one, but they're going to be very brief. And we will start with a lived experience because Dr. Nyanjao stood here and told us that every year we lose 33,600 newborns every year. 70% of those are preventable. We sit in boardrooms and talk about numbers, but we now want to start giving these numbers faces. So wherever there is a meeting, we want to come with people who have lived through an experience so that we are not just talking about numbers. And I just want to give a disclaimer.